Welcome everybody. Welcome to another episode of Lippy Logic, the recurring webinar series that's educational for lipedema. And we have hundreds of you out there tuning in from really around the world. So it's very exciting. And I want to welcome all of you. A lot of you, I'm sure, are recurring people that want to learn about lipedema. And some of you may be new. Let me introduce myself. I'm Dr. David Amron. I'm the host of Lippy Logic. I'm also the founder and medical director of the Roxburgh Institute in Los Angeles, Salt Lake City, and Tucson, Arizona. And I am so excited to welcome back Dr. Karen Herbst. And Karen has been with us for going on, into her second year now. And she is the head of diagnostic and preventative medicine at the Roxburgh Institute and the head of research. And she is based in Tucson, Arizona. We have known each other for, what, about 12 years, Karen? Something like that?
Yeah, I'd say 12.
Yeah. And we
Maybe
speak
longer.
at all the conferences and travel the world together. You're going to Rome, right, this year?
Going to Rome.
Yeah. We were in Germany a couple of years ago. And it's great to have her on here. And she is just a wealth of information and a pillar of knowledge in lipedema. Research-wise, certainly. If you really research papers in lipedema, Karen just comes up left and right, contributing to our understanding of this condition. But clinically, she's amazingly strong, and we work together to develop advancing programs for care of fat disorders, not just lipedema, correct? Durkheim's disease, Madeleine's disease, and other things. And it's so great to have her aboard. I'm primarily a surgeon, and Karen's primarily a clinician and researcher. And we love to get into it with each other. We just actually got into it just before the show started about agreements or disagreements about conditions, especially lipedema. And so this segment is going to be a lively segment. I know that. And we're going to talk about what I call the three pillars of pathogenesis of lipedema. I'm a guy who likes to compartmentalize things in ways that I can understand myself and try to get that knowledge out to others. And, I have been for decades, I've been very involved in this disease and have struggled to get my head around exactly what is going on and piece together the pieces of the puzzle. And the same with Karen too. We're advancing our knowledge of this misunderstood condition. So let's get into it. Lipedema, as many of you know, is a very misunderstood condition around the world. It affects about 10% of the population, and both men and women are carrying the gene for lipedema. It's not just a gene that's only carried by women, but it's very rarely expressed in men, and it's expressed in women. It's genetic, and it presents around puberty, gets progressively worse, and that the common signs and symptoms of lipedema, as we all know. And the knowledge is continuing to increase with research. We share it in conferences, and it's really thrilling, exciting time for this condition. And personally, I'm proud and blessed to be very involved with it. And I know Karen feels the same way. So let's before we get into what I call the pillars of the different areas of lipedema, I want to start by just going through at least my understanding of what lipedema is. And Karen, we've done this before. We did it in Germany. I stood up and I just stood up and I said, can I just run through what I think is going on with lipedema and just check in with you to see if you are in agreement with it. So I'm going to start by saying lipedema is not just a disorder of fat. And I've been saying that for years, and I keep on trying to get that message across. It's not only about fat. And women with lipedema should not only judge themselves by what they weigh, as we know, because there are disproportionate imbalances. And it's really not just a disease of fat. In fact, we can get into this. I think that the primary problem is not in the fat cells themselves. There's other things going on. It is a process, lipedema. And so let me run through what I think is the process going on. And I want you to correct me about things, Karen, as I know you will.
I don't think I'll be correcting you, but I think I'll be agreeing with you that we don't know everything.
Yeah, but this is my understanding of what's going on with lipedema.
Okay.
I think that it is a condition involving a number of different things. And I think we will eventually find that the core of lipedema, one of the initial problems, points to a defect of connective tissue in one way or another. I don't know exactly connective tissue, whether it's elastin or something else, that there's something going on with connective tissue. And probably it's a genetically inherited defect of a protein in connective tissue. And we're seeing it in a number of different areas clinically. We're seeing it in the swelling with lipedema, and that's likely movement. We talked about this beforehand of fluid. I think patients with lipedema are moving fluid across membranes. A lot of them are prone to orthostatic hypotension and stuff like that, or even POTS that many times goes along with it. There's fragility of capillaries in lipedema. That's why they're more prone to bruising with things. There's hypermobility of joints with lipedema and skin too. There's a pliability of skin with lipedema and the Ehlers-Danlos type of thing that goes along with it, with the looseness or weakness of connective tissue. Leaky gut syndrome, as we see, is probably increased in lipedema patients. Again, you've got leaky gut. What do you have around gut? You've got connective tissue surrounding things. And I would say even things like brain fog and stuff that may point to a looseness or weakness of connective tissue in lipedema. So that's what I think is one of the initial things that is going on with lipedema. Then what began to perplex me is how is fat getting into areas like the pretibial region above the shin bone? Because you're kind of taught that you're born with a certain number of fat cells and they expand and contract, but it always perplexed me. How is fat finding its way to that area? Is it moving from other areas? Well, it may be happening because things are moving across membranes of connective tissue. We talked about this before, and I distinctly remember many years ago at FDRS, research being presented showing movement across it, but I think that you're getting cells, possibly stem cells, that are moving into the subcutaneous layer of fat, replicating as early fat cells, pre-adipocytes, because they find themselves in the milieu or environment of other fat cells. So they're likely getting programmed to replicate. And then you're getting inflammation to that process. Maybe it's the dying off fat cells. You're smiling, but we'll check in a second. Dying off fat cells. But the inflammation, is my understanding, is it's not primarily your typical autoimmune inflammation like a condition like lupus or something. There are more macrophages that are involved in it. And that incites chronic inflammation that leads to fibrosis, which is scar tissue in that layer of fat, that increases the congestion more in hydrostatic pressures, and that perpetuates the process of what's going on. That's why I refer to many times you'll get secondary areas of involvement of lipedema as it begins to sometimes sort of migrate down the forearm because of increased hydrostatic pressure proximally. And then that fat begins to almost act like an endocrinologic organ, if I can use that term, and begins to affect your metabolism. It's not only responding to hormonal fluctuations, it begins to actually affect metabolism, and that can begin to slow your metabolism down, and you then can put on weight in other areas. And that's kind of why I think that you've got these three areas. You've got lymphatic involvement, you've got inflammation, and you've got the effect on the metabolism. And maybe it's that order of things going on. Thoughts on that, Karen? And I say this with utmost humility because you're an MD PhD and you're an endocrinologist also. And I want to hear your thoughts on what I just said.
Well, first, I just want to say, happy Lipedema Awareness Month, and thank you so much for having this webinar right now. Because I think we still need to bring more awareness in the healthcare field, but also to everybody.
Always.
I think you describe the complexity of lipedema very well. There's so much going on, which makes it hard to just point our finger at one thing and say, here's your gene, this is what's wrong with you, or here's your metabolic defect, here's what's wrong with you, or you have this, problem with inflammation, here's your problem. And I can tell you about a paper that we published this year with Phil Scherer from UT Southwestern, and he was the one who discovered adiponectin, which is a fat hormone. As you described, fat is an endocrine organ, and adiponectin makes you more insulin sensitive. And a couple of things came out of that paper that are really interesting. As your body mass index goes up, your adiponectin levels go down. And that was not the case for lipedema. The adiponectin levels didn't go down as much with BMI. So women with lipedema remain more insulin sensitive. So because of that adiponectin, well, what does that mean? They can take up fat and sugar very effectively. So they can grow more fat very effectively. So that adiponectin pathway may be part of that metabolic defect and hormonal defect that you were mentioning.
Yeah.
And then we did proteomics and RNA expression, so RNA-seq. So looking at how proteins are made at two different levels. And both of those showed that inflammation was down in the lipedema tissue. So these were tissue samples that actually I took myself and shared them with Dr. Scherer's lab. So I know, I know the areas I took them from were definitely had lipedema. And
Wait,
that
I
was,
have a question. So inflammation is down
yes, in the
in tissue
lipedema tissue.
samples.
Yes, compared to controls.
Does that make sense?
It doesn't make
Does that surprise you?
yeah, we were stunned. We expected to say, oh, look at all this inflammation. We know that fibrosis follows inflammation. What is happening here? So we got a lot of gene expression data, and that was all put into different programs. And we said, well, then what is going on? And what popped out pretty much so on the top in both proteomics and in the RNA expression was that there was something going on with mitochondrial function, that it seemed like mitochondria were not functioning correctly. And mitochondria give you energy, but they also keep your toxin level down. And if mitochondria aren't functioning well, they generate a lot of reactive oxygen species, which causes damage in the tissue. But it's not through like TNF alpha, a cytokine, or it's, which we would call inflammation. It's not through interleukin 1 beta or IL-6. Those are inflammatory cytokines. It was happening due to mitochondrial dysfunction. And if you
Mitochondrial
want to
dysfunction in the lipedema fat cells?
it was in lipedema tissue. So it was the whole connective tissue, fat cells, immune cells, blood vessels, lymphatics, everything was,
But you probably
put
got
together.
in that whole tissue, you probably got a mixture of a bunch of different things. Obviously, like, connective
Correct.
tissue, fibroblasts. You've got kind of
Everything.
old fat cells, if I can say that, the so-called normal
Sure.
older fat cells. You've got the newer, younger lipedema fat cells.
Yes.
Yeah.
Yep. The whole shebang. But, the good thing is that they compared the lipedema tissue to controls. So, to the best of our ability, we had really good controls. We really, evaluated these people and made sure that they did not have lipedema. They didn't have Derkham's disease. They were, quote unquote, they had normal fat as best as we could say. So I think the comparison is real and valid, but it is still surprising, and I'm not sure I understand it. But
Yeah,
maybe the
it is.
assays that we used weren't good enough. Maybe
I don't know.
we need to use different kinds of,
I,
and we
I don't
looked
want
in the
to.
blood.
Yeah.
Yeah, we looked in the blood and we didn't see an elevation in cytokines either. So
Hmm.
we looked in tissue, we looked in blood, we didn't look in urine, but at least in two different tissues, blood and adipose connective tissue, we did not see a lot of inflammation. It was all about the
I
mitochondria.
mean, honestly, I don't want to gate a study, but it just is shocking, and it perplexes me. And I just this whole important area of fibrosis, kind of what's going on with that, because I think of fibrosis again, fibrosis scar tissue, and it occurs from chronic inflammation, right? Fibroblasts get
Yeah, but
involved to it's like
it
a
happens
dome.
after damage,
It's like a
right? It
joint
happens after damage.
after damage, okay, like
So
after an injury. But not only injury, I mean, even with arthritis, which is the
Yes.
degeneration of something. Inflammation is definitely involved, and the inflammation is creating fibrotic scar tissue. And I think that same type of process likely going on in the layer of fat and other areas with lipedema. So I don't know, just it's hard to like sort of swallow that um, there's not increased inflammation or something going on with inflammation. And that's why
Well,
all
I will
these,
tell you
go
that
ahead.
when I sit around with other investigators, they're torn. There's some that say there's more inflammation and there's some that say there's less. So
Okay.
it's still a very active discussion in the lipedema field. And that it's so something different's going on that we don't quite understand. So maybe lipedema will teach us something new about inflammation, mitochondria, reactive oxygen
Yeah.
species that we didn't understand before
So
that leads to fibrosis.
okay, so when we give patients these preventative strategies in different areas, a huge preventative strategy is dietary a dietary strategy. It's not just dieting, it's avoiding things that we either know or feel increase activity of lipedema. Let's just say gluten, for example. A kind of a no-no with lipedema. Is gluten increasing inflammation? Is gluten simply increasing swelling and flow across membranes? Do we have any information about that?
Well, I think that there's so many different things that can generate inflammation in the body, right? So gluten is, especially gluten from in the US, like bread from the US, not necessarily Europe, it tends to be inflammatory and people tend to have a hypersensitivity to it, a reaction to it. It may not be a true allergy, but
Mhm.
they might have the gene for it. They just might have an intolerance. But
Mhm.
I do think that if you add, there's something going on in the lipedema tissue. I don't think we can put our finger on it yet, but if you add in inflammation from allergies or gluten or
Mhm.
um, under exercise or any kind of toxin, then it's going to make things worse.
Mhm.
So I don't think we're denying that things from our environment can make us as human beings worse.
Yeah.
What we're trying to
Hmm.
figure out is what are the very unique aspects of the lipedema tissue. And honestly, this paper makes me really think that we're not there yet. And there's something else that's going to be discovered and that
Hmm.
lipedema is going to shine a light on.
Hmm. Hmm. When we sat a couple years ago and this concept of developing a diagnostic and preventative program in Arizona, we tried to kind of put things in these different ways of approaching it. And before we get into questions, because there were tons of questions from all you guys, and honestly, I read them yesterday on the way back on the plane in Utah, and I'm like, oh my goodness, there's such sophisticated questions from this group of patients. It's amazing. Before we get into
Yeah.
those questions, I do want to kind of run through the different areas that
Mhm.
we're addressing in terms of how we're approaching lipedema. A lot of it's preventative stuff. It's not just surgery. I mean, surgery has its own role, and this webinar is not to talk about surgery, but a lot of it's to focus on preventative stuff. So, just to appease my mind, I want to run through with you these different areas of things, the lymphatics and that whole area of what's going on with lipedema and things that we do to improve each of these areas with it. Because I think that
Mhm.
things that we're doing preventively are kind of following these different categories of things. So let's talk about the lymphatics because that has to do with swelling. One of the areas that I've
Yeah.
said that preventatively, when a patient asks me, my daughter is in her teenage years and I think she has lipedema, what can be done to avoid, or delay the need for surgery? I will generally answer, well, respectful dietary strategy, being on a diet that is avoiding some of the apparent triggers of lipedema. Number two, pay attention to swelling and compression therapy. I
Mhm.
think it's an important mainstay of things because swelling is one of the first things we're seeing with it in the process.
Mhm.
So helping controlling swelling is important. all the decongestive strategies, compression therapy and garments and pump therapy and MLD therapy and fascia busters and vibration plates and all those wonderful things. What are we doing in that category? I think we're helping lymphatic function, right? Kind of maybe
Yeah,
only,
and I
we're only helping lymphatic function in that category. I mean, it's not really an inflammatory. You could say it's helping inflammation. It's primarily helping lymphatic function and stuff like that. CVAC that you're doing, is that helping flow and lymphatic function, do you think?
yes, I
Yeah.
do.
Yeah.
I think, yeah, when you get out of this, the CVAC, which is a cycling hypobaric chamber, you usually have to go to the bathroom. So it's definitely cleared fluid out of the tissue. But I think one of the important things that the CVAC does is it improves blood flow into the tissue. And all that fibrosis that you've been mentioning in the lipedema tissue, if you think of it as like a cage, whatever's in that cage, muscle, fat, vessels, lymphatics, everything is getting congested. And
Yeah.
so improving blood flow in and lymph flow out is important. It's not just lymph flow out, it's getting that blood in there so you can heal.
Yeah, I mean, I guess it's I throw all this term, it's kind of detoxifying the areas in a way. Otherwise, things are building up and perpetuating the process of things. So decongestive stuff is very important. I mean, it really is kind of a mainstay of preventative measures, and addressing the lymphatic system is part of it. Just flow in general. I think things that begin to negatively impact flow make the condition worse. As you're getting more congestion and more fibrosis or whatever it is, you're affecting lymphatic flow or just flow, not only lymphatic, but capillary flow also. And that
Right, leak.
and that can lead eventually to damage of the
Mhm.
lymphatics in that term we call lipolymphedema.
All the tissue.
Yeah.
All the
And more,
tissue.
yeah.
And I think that the decongestive therapy, the compression garments also help with venous disease. And a recent paper out of Switzerland showed that like 86.5, I'm not sure I got that number exactly right, but 86.5% of women with lipedema had some kind of venous disease.
Yeah.
And whether it's the classic um, superficial veins that can be treated by a vascular specialist is probably not the majority of that. There's venous disease that we really don't understand. So many women with lipedema have spider veins. I think
Yeah.
spider veins are a marker of underlying venous disease of some kind. And also fragility of the vessels, the easy bruising also comes from those small veins. And if they
Yeah.
get that lacy looking pattern on their skin, especially on the medial side of the arms or on the thighs, that's dilated small veins under the skin. So when you're doing
Yeah.
that decongestive therapy, you're
Yeah.
treating the lymphatics and the veins.
Yeah, I think maybe the core could be again that weakness of connective tissue and fragility of the vasculature, not only the small capillaries, but the larger veins too. And then you get more
Mhm.
congestion and more pressure exerted on those veins, and that's vicious cycle begins to take place with things. Um, okay, I'm trying to think of other things we do to help the lymphatic system preventatively. I mean, we covered a lot. I think that, I'll just comment. I think that surgery, like what I do when I'm in there, again, I talk about this. It's not only just removing fat. You're not only just putting a vacuum there and sucking out fat. You're doing this surgery to do so many things. And I think that a huge part of surgery is not only just how much fat you're removing, but the proper improvement of fibrosis. I kind of feel when I'm in
Mhm.
there doing my work on things, I'm freeing things up. I'm removing that fibrotic scar tissue that's going to hopefully help with decongestion and lymphatic flow. And I think that even patients with some lipolymphedema, unless it's just end stage and you've got really permanent damage, you see improvement of it with the liposuction. So, those are things also that's all helping lymphatic flow, not only just removal of fat. Okay, let me jump into inflammation. Things, go ahead.
Oh, can I just say my part of that?
Yeah.
So I would say there's 4 supplement medications that can improve lymphatic pumping. So I think the GLP-1s do it by decreasing inflammation because in an inflammatory environment, you get decreased lymphatic pumping.
Mm-hmm.
Amphetamines, including
Mm-hmm.
like phentermine, dextroamphetamine, Adderall, are well known to improve lymphatic pumping, they're just out of favor because they're controlled substances and doctors don't like to prescribe them. And then diazepam has been
Mhm.
shown to decrease inflammation around vessels, blood vessels, but it also has been shown to improve lymphatic pumping. And then,
Same
yeah,
here. That's
yes, yes, yes. You have, yep, micronized purified flavone fraction, which is the best diazepam to
right,
have. And
MPFF.
then finally, arginine has been shown to decrease leaky lymphatics. And I'm
Yep.
sure it's also decreasing leaky lymphatic
Yeah.
vessels as well.
And you did some of the research on that?
I did research on the amphetamines, not the GLP-1s.
Hmm.
And yeah, I think that's about it. But
Hmm.
I didn't do anything on arginine. That's actually in the published literature if you look it up. Leaky
Hmm.
lymphatic and arginine.
Hmm.
The problem with
So,
arginine is you have to take so much of it.
yeah,
You have to take 3 to 4 grams, 3 to 4 times a day.
yeah,
And I
yeah,
don't know about there are extended release arginine available on the market, but I don't know. There's not a lot of data on those.
yeah. Okay, let's jump to inflammation. What people can do preventively to reduce inflammation, although we just talked about this, it may not be involved in lipedema, which I can't swallow that. I can't swallow that. I just think there's involvement of inflammation, even though the tissue samples may not have shown something, there are blood tests, but what people can do to help reduce inflammation. I mean, just running through things. So dietary strategy is one
Agreed.
thing,
Yep. And
avoiding
there's so
things.
many different ways to eat to reduce inflammation. And I
Hmm.
think it's personal for you as a
Hmm.
person. And so if somebody says, everybody has to do a plant-based diet, that's just not correct. That may not be
Yeah.
correct for you. So you have to find out what you can eat that is anti-inflammatory and that you can sustain.
Yeah. That I love the way you're saying that because I think it's so, first of all, to tell patients, and especially a lot of patients with lipedema have been told all these things, you can't, and many even have eating disorders with it and have triggers. So I think we want to be careful about saying you absolutely cannot do this and that, but you want to be on a generally respectful diet towards lipedema, and avoiding some of the certain triggers. And there's many different strategies. I know you have been a proponent of the RAD diet for
Mhm.
years. Ketogenic type of diets are good, but they can be a little bit restrictive and maybe not so good long term. But you've got to find a diet that's working for you. And I literally pulled back on going into a lot of deep recommendations about this because there's so much chatter in terms of all these different paths to a respectful
Mhm.
diet. And there's a lot of great information online. There's
Right.
some good books written about it.
And I think when you say like plant-based diet, there's so many different ones that
Right.
you're not talking about the same thing. Keto, there's so many varieties and ways you can change that up for a person so when you say it, it's not just one thing. It should be your diet should be flexible for you and your lifestyle.
So what other, so outside of dietary
Mhm.
things, what else could a person do to help reduce inflammation?
I think movement,
Hmm.
definite movement. So I think
I
the whole
never
body
thought about that.
hydration.
I thought of
Yeah,
movement helping flow, but movement can help inflammation.
absolutely.
Hmm.
Gets improving flow. Let's say that there are these inflammatory mediators in the tissue that we couldn't find, but there's some sort of toxin in the tissue, maybe that we're not
Hmm.
identifying,
Hmm.
and that toxin is making changes in the tissue. So if you're moving, you're moving that lymph fluid out of the tissue,
Hmm.
you're moving blood in, you're washing the
Hmm.
tissue. So washing the
Hmm.
tissue by exercise, I think any kind of
Hmm.
exercise is important.
Hmm. Somehow that
And
just went over my head in
and
terms of
hydrate,
movement,
right?
exercise, but it totally makes sense. I'm sure there's studies that
Yeah.
show that exercise, even outside of lipedema, helps with inflammation. So, okay.
Agree.
Other things. So I mean, this is a huge area because probably spent a whole segment on this GLP-1 agonists. Now we've talked about this. I think of them primarily helping metabolism, and they do, but you've said to me many times you think that they're really primarily working by helping inflammation.
Right, exactly. And
Hmm.
what inflammation, so we should do a research study on looking at the tissue before and after GLP-1s. And actually that research is going on in lipedema stem cells right now. So that data should be available pretty soon. And I think maybe that will help us find out like really what's going on in the tissue. What is improving, because there is a lot that is, but the GLP-1s affect not only your gut, but your brain, and then your brain affects your body and your metabolism and your metabolic rate.
Yeah.
It's very complex.
And I naively thought early on that that reduction of inflammation was due to people eating less inflammatory substrates. But there's something specific about GLP-1s that is helping target inflammation, as we now know. In my experience, I'll just say this, that maybe it's because I see so many of the patients that have not improved on GLP-1s as much with it. They're coming to me for surgery. I think that the percentage of patients, I mean, virtually all patients lose weight. I mean, they're going to lose weight. But the ones that really are making an improvement of the lipedema and reduction of inflammation and pain, I think it's a minority and not the majority. I could be wrong about that, but I see that most patients lose weight, but most patients haven't really lost weight as much in the areas of lipedema. They'll lose weight more in other areas, visceral fat, and this and that, the areas that lipedema don't improve as much. And a lot of times the symptoms haven't improved as much, but there seems like a subset that they get huge improvement with it, that their fibrosis even begins to soften, they get reduction of pain, but that's not the common thing in most patients.
Yeah, I see the patients who they pretty much have a drastic reduction in pain, and then the weight, is coming off as well. But I talked to somebody on Thursday and was renewing her GLP-1, and she still has a lot of pain and swelling in her legs. Now she's already had surgery, and she's already had her veins looked at, and she's still having this issue. So I don't know what it
And
is.
she's on a GLP-1 also?
Yes,
Well, those are, I mean, that's the very perplexing type of patient. I mean, if
it is.
they had surgery and surgery was done properly and completely, first of all, that should in and of itself greatly
I'm pretty
improve
sure it was
pain.
you. Pretty sure you were the
Well,
surgeon.
so
I
this
feel
is this.
comfortable, right?
Okay, so that this comes up every now and then, which is pretty rare, but you've got a patient that I may have made massive improvements in things, but they're still having pain, which is unusual. And then they come to
Mhm.
you. We look into why things are going on, whether it's testing and stuff like that, try to understand things. They go on a GLP-1, they're still having pain. This is a very challenging type of patient, why that is still going on.
Yeah, it's very challenging. And
Very, very
that you're right,
perplexing.
that it's not as common. And I have other patients who have gone up on a GLP-1 in dose, and let's say they're on tirzepatide and they're on 5 milligrams or 7.5 or 10 milligrams, and they're not losing weight anymore.
Hmm.
But the benefit of it is it's maintaining their weight.
Hmm.
And I think that it's very important to maintain
Well,
your
that's
weight.
why, yeah, I think
Gain.
also that, the use of microdosing, which is taking place now, but in the future is a very interesting thing in patients with lipedema.
Yeah.
I think GLP-1s definitely have a role. You and I get into this chicken and egg thing a lot of times in terms of what really comes first, and I think that every patient with lipedema certainly can go on a GLP-1 and see improvements with there's no harm to it. Maybe every patient possibly should go on it.
Mhm.
Myself as a surgeon, I want to go in there and I want to make the changes and decongest things and then, many times consider it as an add-on afterwards. But then there's some patients that really need to go on it beforehand. They're so inflamed.
They're so inflamed.
They're so
Yeah. And
inflamed, they should be calmed down first, the GLP-1s, and then go
yeah,
ahead with surgery.
yes, I agree. But there's others that, have gone on GLP-1s just to reduce, inflammation, and
Yeah,
they're very small. So we
yeah.
get the inflammation down, but they're still tiny. They're not losing huge amounts of weight. And then they go in for their surgery. So
Yeah.
I think it's such a wide variety. There's so many, inflammation is so complex. We were
Yeah,
talking about
yeah,
like, what is inflammation? There, I'm working on the genetics, and every time I turn around, there's another pathway and another pathway and another pathway. And so maybe the reason we didn't find it in lipedema tissue is because there's so many pathways, and we looked at like classic inflammation. We didn't look at unusual inflammation. And I would like to just reference Dr. Saverio Cinti's work from Italy, where he showed that the blood vessels in lipedema by electron microscopy were fragmented. Chunks of connective tissue had come off of them. There was a lot of calcium around vessels, around fat cells. And he said in all of his 45 years of doing electron microscopy, he had never seen anything like it. So how could classical inflammatory testing figure out what lipedema is when this scientist had never seen anything like it before in his life? So, that's what we're dealing with. We're dealing with something that's never been seen before.
Yeah, yeah, the inflammation is,
That's
I mean,
scary and exciting.
yeah, and that's why it's so perplexing to not find increased inflammation in patients, because the inflammation seems to play such a role in things, in the fibrosis.
But
And
again, there's so many different, like I've learned so much more about how inflammation works and these different pathways
yeah,
that I
yeah,
don't, how are you going to test for all of that?
yeah,
You know how much money that would cost and how
yeah.
much sample you would need?
Yeah, yeah. I think a really important area to look into, and I've said this, is the different patterns of fibrosis. Me being, a surgeon, being in there, I run into these different patterns. I've talked about this, the nodular, the strandy, the swellers that have that strandy type of loose connective tissue, the dense fibrosis, that cement-like stuff that's prone to lipolymphedema, and the granular, which to me kind of clings under the lymphatic capillary network under the skin, like little grains of sand with things. I mean, looking into that and understanding that, genetically people are inheriting patterns of fibrosis. When I see a grandmother, a mother, and a daughter, I do surgery on all three generations. I'm generally seeing the same pattern of fibrosis. Really interesting to look into that.
Yeah,
Uh,
I remember trying to document that at another place that I worked, and that would be really nice. We had a whole
yeah,
table, whole
let's
list of everything, but
let's let's
you
get a study
surgeons
going
got,
on that.
yeah, you surgeons got to do that because you really
Yeah.
get to do it during the
Yeah.
surgery.
Yeah, you get a
Difficult.
really interesting perspective of things being in there. You really form an understanding, special understanding what's going on with this disease being in there. Okay, so we talked about lymphatic stuff you can do preventively. We talked about inflammation, primarily dietary strategies. You educated me that movement's also going to improve that, the GLP-1s. So now let's move in that area of metabolism, which is, I literally have to look up. Sometimes I like to look up basic words to
Yeah.
check in with Webster, what they mean. And metabolism, if I remember correctly, was a complex set of chemical reactions involved in the body to sustain life and
Mhm.
involved in energy production.
Yeah. And
Uh,
guess where a lot of that happens?
guess
In
where a
the,
lot of it happens?
yep, in the mitochondria.
In the mitochondria. I think a lot of it happens also in fat cells too, but it's happening throughout the
Yeah.
body. I mean,
Yeah.
yeah, with the mitochondria, of course, that's the main thing of energy production with things. Of course, we learned that in medical school.
Right. So mitochondria use sugar to create energy and fat to create energy. And you have to get, once fat leaves a fat cell, it goes onto the carnitine shuttle, gets on the carnitine bus, and then it goes into the mitochondria, and that's where it's broken down and utilized and energy is made. So there could be problems with releasing fat from the fat cell, and we've seen some genes that have issues with that. And the interesting thing about that is it's primarily seen only in women. And then you've got your carnitine, so you could check for carnitine deficiency in the blood. And then mitochondrial function is harder. We did some mitochondrial studies and we do all this work, muscle biopsies, and you have to process them a certain way and take them out a certain way. And then you do the experiment and they go, oh yeah, sorry, that didn't work. and then
Mm.
there's your
Mm.
whole, there's
Mm.
weeks and weeks and weeks and weeks of work. So
Yeah.
mitochondrial function is harder to test. So that makes genetics powerful because you can look at, there's different complexes of proteins that function to generate the energy, and you could look for mutations or variations in those genes.
So how do you think the metabolism um, gets negatively affected with lipedema? I know it's a big question, and I'd be
I,
surprised if you actually
I
know
don't
the answer. Yeah.
Yeah,
Yeah.
I've been looking at the genes in the Krebs cycle, which is how you process carbons or from
Mm.
glucose. We see stuff, but we don't see anything consistent and clear.
So
And
insulin resistance begins to occur as lipedema progresses, right? Because
we
you've got
talked about
more.
we talked
Mhm.
about adiponectin, remember? So adiponectin is supposed to go down with BMI, and it doesn't do that in lipedema. There's a disconnect there. So adiponectin stays higher with higher body mass index. So
Mm.
insulin sensitivity is being preserved for a
Mm.
longer period of time. And at some point, though, the fat, maybe it becomes more congested. Maybe there's more leaky vessels, maybe veins get involved. And then you start getting metabolic syndrome. And that's
Right.
when I think inflammation starts to go up. But that's metabolic syndrome on top of lipedema, not metabolic syndrome being lipedema.
Do you think that the increased amount of tissue and fat cells that progressively begins to occur in lipedema affects the body's ability to provide enough insulin to meet demands of all those cells?
Uh,
You un- Do you understand? Do you understand what I said?
yeah, yeah,
It's,
yeah.
it's a
So
mouthful.
yeah, when you have insulin resistance,
Hmm.
or pre-diabetes, your insulin levels tend to be very high because you need more insulin to get that glucose into the cell.
Hmm.
And I test for that. I do fasting insulin and glucose levels. And I think if there's any question, that should be done. A hemoglobin A1C doesn't tell you because you can have normal sugar levels, but really high insulin levels. And you can also do an oral glucose tolerance test if you wanted to go that far. But I
Hmm.
don't think the pancreas is altered in women with lipedema. I think they can effectively make as much insulin as they want. It's when the tissue, you know, being in that congested environment, that you decongest, having that congested environment makes it very hard to metabolize things effectively. Receptors are damaged in that environment, not only insulin receptors, but thyroid hormone receptors, so that women with lipedema, as they gain more adipose tissue, start to have higher and higher TSH levels. They become
Hmm.
have subclinical hypothyroidism and leptin receptors. So women become leptin resistant in a way. So lots of damage going on in that tissue. Not
Yeah.
necessarily, not necessarily maybe by inflammation specifically, but
Yeah.
by that congestion, which is what you so effectively reduce. Even, what the leftover lipedema
Uh,
tissue for people on GLP-1s.
yeah. So what I've seen, even before GLP-1s, years ago, is that patients with lipedema that I did surgery on, I removed, liters of that material and decongested, many or most of them would subsequently lose weight in other areas, not just the fat you've removed, but they'll then say, you know what, Dr. Herman's like, I lost an extra 30, 40, 60 pounds in the last year or so with things like that. And I think that may be going on because you have improved their metabolism
I don't think
or
so.
no, have
I
you
think
removed,
it's your decongestion. I really
did you
do. I think
really?
you free up that tissue to now have, like here's something. You have an inflamed joint, right?
Uh-huh.
And they inject sugar into it, which is called prolotherapy. And that
Uh-huh.
sugar generates inflammation, and therefore the body starts to repair. You
Mhm.
break up that, you get rid of some of all that junk, the fat, the
Mhm. Mhm.
fibrosis, you get rid
Mhm.
of a lot of junk, but then the body has to repair. It's given a fresh start to make healthier tissue that has
Yeah.
flow.
Yeah. I've always been like, and I've said this, people are so focused on how much fat is removed. And I feel that if no fat was removed, I know this sounds weird, and you just go in there and you release and break up all that stuff, you're going to make huge improvements in almost everything with pain and decongestion and all that stuff with it. Because again, the fat cells themselves are not really the primary problem, I think, going with lipedema. They're just kind of doing their job as fat cells with things. And just the release of all that fibrosis is going to make huge improvements. But what I think may be going on also, Karen, is that when you are removing all that hormonally active material of the fat, right? Because the fat is not only responding to hormones, it's producing hormones like estrogen that progressively begins to slow the metabolism down. And now you've removed all that, and maybe you've removed something that's slowing down metabolism. It's not only just decongestion. I think the fat itself is also tending to slow down metabolism even more so. So now we get into the whole kind of hormonal balance of what's going on with lipedema. Another thing I've seen after surgery is that patients, many times their hemoglobin A1C improves after that. Maybe that's not a big surprise. Has there been any studies looking at hemoglobin A1C after lipedema reduction surgery?
There's not a lot of before and after for
Yeah.
inflammatory
I've seen I've
mediators. I
seen
mean,
I've
we
seen
really,
thyroid
really need to do that.
I've seen thyroid improve also. Maybe that makes sense a little bit with it.
And that's been shown in non-lipedema obesity as well, so
Yeah,
that it makes sense.
makes sense.
Yeah.
So now what can people do, to make metabolic improvements preventatively in their own body with things? And let me first ask, is metabolism linked to the hormonal stuff that's going on? Is that kind of a whole area?
Absolutely.
Like
Absolutely.
metabolic hormonal stuff?
Yeah.
I kind of think of it. It all kind
And
of
the
works
immune.
together.
Yeah, the immune cells are linked to metabolism, which are linked to hormones. So women's immune system is very different from that of a man. So like if a man and a woman were in a car accident, the woman would
Mm,
survive, the man would be at greater risk because of
mm,
the immune function.
hmm.
And then a woman
Yeah,
goes into menopause and then she has the same
yeah,
risk as a man.
yeah,
So,
yeah,
so hormones are super important. And there's, the more I look into the genes, we keep finding genes that are important only in females. Like they've looked at them in men and nothing happens. So then
yeah,
they decide to surprisingly do studies on women too. And voila, the effect is different in women.
yeah.
So we need more male-female studies. I think that would help us tease out lipedema a little bit more. I think in the next 5 years, we're going to find out very surprising things about pathways that we maybe aren't like classic inflammatory TNF alpha IL-6 pathways. There's something else. And that's so exciting that
Yeah.
we can find that out.
It really is. It really is. And besides the whole, increasing awareness of lipedema, which is, slowly going on, I think with research is going to be a whole another level of understanding about this, which would be great. Okay, let's, I don't want to lose everybody out there because there's hundreds of people listening from around the world, and I've got, probably hundreds of questions here to go through. We're not going to be able to go through all of them. I want to thank first Jasmine and Chelsea, who've done a great job of compiling all these things, putting them into different categories. So let's tackle them. Okay, let's get some of the questions that people had. We'll also try to get some live questions out there too. So some questions on they're broken into different categories: diagnosis and early steps. Let me just kind of go through these. We'll see if we can bang them out. Karen, you and I. What is the first step to start curing my lipedema? Well, one of the first steps is, get properly diagnosed with lipedema. But that's a big question. I mean, the word cure itself is a tough thing. You're not unfortunately curing it. You're making great improvements in managing lipedema. You want to comment one of the first steps that people can do?
Manage is a good word.
Yeah,
I think we already touched on it, and that would be, lifestyle, eating plans and exercise plans.
yeah, yeah, yeah.
But
I
again,
think
but finding a good advocate for you that's going to work with you and support you and listen to you and hear you, and also has
yeah.
some knowledge about lipedema is great.
Yeah, that's a tough thing. I think that, it falls into different areas. I mean, dietary strategy, and a lot of people can get good information online about that in terms of guidance. I think linking up with a good decongestive therapist is very important. Compression is important, and finding somebody to help guide you that process, compression garments that work for you and other strategies like pump therapy and MLD therapy. Those are really the main areas with things. Controlling your hormonal fluctuations. I mean, it's a big area to talk about also, is something that is important to look into if there are hormonal fluctuations going on. We could probably spend a whole segment talking about that. You know,
Two, at
let's
least
not
two.
let's not get into that now.
I just want to say that I am licensed in multiple states. And so if
Yeah.
you need like a first step, I can probably help you with that if
Yeah,
I'm licensed in your state.
multiple states and increasing by the month.
Increasing by the
I think
month.
that's what,
Now,
like 24 now, about half the states are licensed in. Something like that.
not, I don't think quite, but close
So,
enough. Yeah,
okay.
we're getting there.
Okay, what doctor do you see to be diagnosed? Again, another tough question. We've talked about this, Karen. Part of our goal, especially with Lipedema Society, is education of doctors so they can properly learn to diagnose lipedema. It's hard for people to know who to go to nowadays to get diagnosed. We do diagnosis virtually with things, but guidance on that. What type of doctors see to get diagnosed?
Yeah. So I have done a lot of or given a lot of talks to vascular specialists. So I think that would be a good first choice. In fact, the Center for Vein Restoration, all of them know about lipedema because I've given talks at their annual meetings, and other people have given talks to them on lipedema. So I would say try a vascular specialist first. And when you call them, say, do they know lipedema?
Yeah, I think that the vascular guys are probably more to any specialty, the ones that, should or could know about lipedema with things. And I think
Mhm.
that they really have responsibility. I think they're seeing a lot of patients with lipedema, and the negative sometimes that they'll diagnose with vein issues and not realize there's lipedema going on also and how it impacts it. So I think you want to know that the vein or vascular person you're seeing understands lipedema and can diagnose you with that also. But really, we got to be teaching primary care
Yeah,
doctors. We
we do.
talked about this. One of our
We
goals
do.
is, I mean, come on, we got to be screening for it at a
Right.
younger age. I mean, OBGYNs, pediatricians, they're the ones
Yeah.
that we really got to be targeting to diagnose lipedema at an early stage, start the preventative measures. Okay. How can we, I guess the patients ask us, educate our primary physicians on lipedema? How can we tell doctors that we know about lipedema?
I think sharing the standard of care for lipedema in the US would
Yeah.
be one way to do it. And you could send them to our website,
Yeah.
our ALT website, or the Roxbury website to learn more about lipedema. And also your doctor could feel free to give us a call. I
Yeah.
like talking to
Yeah. I
doctors.
say that's the same thing. I tell them also, have your doctor call, have them come and spend a day with me, learn a lot about things. But, this is, I really, I struggle with this myself. I kind of want to go about wherever I am talking about lipedema and even if you see it on the street, sometimes you want to go up and maybe find a way to mention it, but that's very tough, very difficult. But one thing I think that one thing I think that patients should try to do is take every opportunity to educate healthcare professionals about it and your doctor, you know?
Not a lot of them do. They say, I educated my doctor on how to care
Yeah.
for me, and they realized that they had six other patients who had this.
Yeah, especially Lipedema Awareness Month. We got a few more days left. Go give your doctor a call
Yes.
if they don't know about lipedema and educate them on it. Okay. Um, let's see what else. Da, 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 da. How do you know if the swelling and pain is lipedema or just a symptom from another autoimmune disease, or does it even matter in regards to treatments? Oh,
That's hard. Like for
yeah,
example, signs and symptoms of vein disease overlap very closely with those of lipedema.
yeah,
Um, Even fibromyalgia signs and symptoms can overlap with lipedema. So it's really hard to tell.
yeah.
Uh,
Well, it's hard, but it's not that hard too. So I think that, you go back to, what the common signs and common symptoms of lipedema in terms of diagnosis. I mean, the signs are that characteristic disproportion we tend to see in more of a circumferential pattern. You've got the type 3 and the type 2. You've got a characteristic look of lipedema in the extremities primarily. And then the symptoms, the pain or tenderness with lipedema, it tends to be a different characteristic to the pain with it. Typically, that's sensitivity to pressure that you have with lipedema that you don't commonly have with other types of either autoimmune or conditions. But I guess with veins, you can also have sensitivity to pressure. But in my experience, that type of pain is more like a constant aching pain and not that tenderness when I get a blood pressure cuff put on or I get a massage done or get a pedicure done, that characteristic sensitivity to pressure. But again, about 15% of patients with lipedema don't have pain, right?
Right, right, right,
So,
right.
yeah.
Yep.
All right. Let's move
Especially
on
early stage.
to inflammation. I got this marked here as a question for you, Karen, specifically. What is the best protocol for identifying inflammation stemming from nutrition and diet? Ooh, tough question.
That is a tough question. Well, I mean, taking a good history, to find out,
Yeah.
what you've been eating and what kind of exercise you've been doing. But and sometimes it's very difficult to find inflammation. Look at, we just published a paper and we couldn't find inflammation. So, but usually what I do is the classic C-reactive protein, erythrocyte sedimentation rate. I also have a new calculation that I do looking for systemic inflammation that involves the complete blood count. So I look there. I also do labs for mast cell issues. If I think mast cells may be playing a role, those are very difficult because the mast cells are within the tissue and you have to catch whatever they secrete coming out of the tissue into the blood. And then I look at classic cytokines, TNF alpha, transforming growth factor beta, if I can get it, and then TNF alpha and a couple others. But I mean,
Yeah.
it's hard. It's really, how do you feel? Do you have pain in your tissue, and are your lymphatic vessels sluggish? Are you getting swelling? That's inflammation right there.
Okay. Next question, maybe tough question, big question. Thoughts on MRT, mediator release test, to determine what triggers inflammation? Do you want to attempt to
Yeah,
tackle
sure.
that?
So yeah, so classic allergy response includes immunoglobulin E, so that's an antibody. And you can look for that in blood, and you can also do the patch testing at your allergist, although there fewer and fewer of them are doing it for food because they say there's false positives. The MRT test is different. You're looking at your immune cells and you're showing them food, and if they contract in the presence of food, that means that they've released their contents into the environment to try to fight against that food. So it's a non-IgE mediated immune response. And, unfortunately, there aren't a lot of good studies on the mediator release test, although there are some patents associated with it. So I did a test. I have food allergies. And so one of my food allergies is not wheat. So I thought, sweet, I can eat some bread. So I ate bread for a while and I didn't feel very good. So I did the MRT test. And sure enough, I reacted to wheat. So
Hmm.
I think it gives you, if you have done your food, blood testing, patch testing, whatever you've done, and you're still having issues with your gut and you want to see if there could be something else to give you some information, I think a mediator release test is an option. Other people do food sensitivity tests like IgG, but those tend to vary with the food that you eat.
Okay, good. How does cortisol from stress impact inflammation and lipedema?
Mhm. Well, cortisol is a great anti-inflammatory, so it will reduce inflammation down, but it
Mm,
also makes fat grow and it
mm,
makes blood vessels weaker. And when blood vessels are weaker, they leak. And if they leak, then your lymphatics have to work harder. And we know that they're already working hard in lipedema, so it could cause swelling. So I would
mm.
say cortisol increases fat and swelling. At the same time, it decreases inflammation. That sounds like lipedema. Hmm.
Yeah. Okay. Moving on to lymphatic system and fluid management. Is there a way to unclog your lymphatic system, and how do you maintain a healthy lymphatic system? I mean, I'll just jump in. I think that the stuff I do is a major unclogger. It's almost like Roto-Rooter going in and just decongesting and releasing mechanically and vaser and this and that. I think it improves things, not only just removal of fat, immensely the surgeries themselves are a major internal decongester of the tissues. But certainly, there's a lot of external stuff. Like we touched base on all the compression strategies, fascia buster and pump therapy and MLD therapy and this and that. Anything to add to that, Karen?
Uh, I have never seen a study showing that the fat presses on the lymphatic system causing dysfunction. So
Mm,
it
mm,
doesn't mean that's not true. I just have not seen it. And we do know that even in early stage lipedema, that the lymphatic vessels are pumping at a very quick rate,
yeah.
even though they may not be doing the best job because the walls are a little floppy and the lymph kind of pools out of the lymphatic vessels. But
Mhm,
I do think that leaking from the capillaries is impacting the
mhm,
swelling in the tissue because the
mhm,
lymphatic vessels can't keep up.
mhm.
And there
Okay.
may be leaking from the capillaries. We really need to look at that. But I was told by Eva Sevick from UT Houston that if she said, Karen, if you have leaky blood capillaries, you have leaky lymphatics because the same mediators are affecting both.
Yep. Yep. Okay. Next question about exercise with lipedema. Um, can intense exercise cause inflammation? Should people with lipedema avoid vigorous exercise? Very,
Right.
very,
I
very
do
reasonable
think that.
question.
Yeah, it's a great question. I do think
Yeah.
that intense exercise, like running 250 miles, that's going to generate a lot of lactic acid, and that can
Yeah.
cause damage to the tissue.
Yeah.
But I, I would, I would not want to ever stop anyone from doing vigorous exercise. I think that's
Yeah.
really important. And I
I kind
think
of feel the same way
you can do
too.
things before and after that help you recover quickly. Like you could, wear your compression garments. You could use a pump after. You could go swimming after. You could take
Yeah.
a
Yeah.
anti-inflammatory before, like alpha lipoic acid or a micronized purified flavone fraction.
Yeah, I feel the same way. I'm really, reticent in terms of telling patients with lipedema you cannot do any type of exercise. I think if it feels good and it's your body's responding in a positive way to it, do it and go for it. I think that patients maybe with, very advanced lipedema, shouldn't push themselves too hard or lipolymphedema, but they're going to be affected many times with mobility issues anyway with it. And they're going to want to do more like, water exercises, but do whatever I think feels comfortable and feels right. I guess, if it's 110 degrees outside, I mean, think twice about, overdoing it and stuff like that. If you're noticing you're having more swelling going on, maybe that's a little bit of a sign right there. If some activity you're doing is really creating a lot of swelling and inflammation, try to avoid it. But I think for the most part, exercise is very, very good with lipedema, all types of exercise. Okay.
I just want to say something real quick. I want to just recognize Patty Cornute, who we
Uh,
lost this year. She had stage 3 lipedema, and she was a huge proponent of exercise for women with stage 3.
yeah.
And she weightlifted. She did just incredible things and was just a real pillar to the community. And she is definitely sorely
Mm,
missed.
mm. Mucinex. Next question. I know you're a lover of Mucinex. I've heard people talk about Mucinex to help thin out lymphatic fluid. What are your thoughts?
I, you know, If you, Mucinex is used to thin your mucus so you can get it up out of your bronchial tubes. And what is mucus? So I had to look that up. What is mucus? And it is made of like glycosaminoglycans, complex sugars. And if you look up the mechanism of Mucinex, it doesn't exist. They talk
Mm,
about how it helps ciliary motion, but there's even no good data on that. So I think it is loosening up those complex sugars. And what do we think is in the interstitial space and lipedema are complex sugars? Just
mm,
like with anytime you increase adipose tissue, you increase the amount of complex sugars in that interstitial space, which congests it. So that's another thing that you're removing with lipedema reduction surgery is those glycosaminoglycans. And I
mm,
think it
mm,
definitely works in some women. it doesn't work in all women, and
Mm.
some people with mast cell actually react to the excipient ingredients in
Mm.
Mucinex.
Mm. I was just going to ask, is it safe in all patients? But, there can be a negative reaction in certain patients with mast cells.
Just like if you look at glutathione, for example, glutathione is a great anti-inflammatory. And one of the things in that paper that we reference that we published this year, we recommend glutathione, but glutathione activates mast cells.
Mm, mm, mm. Okay, goes on to metabolism and weight loss. How does alcohol consumption affect lipedema and metabolism? I would think it's just purely because it's a vasodilator, but I'm sure there are other things that are going on too.
Yeah, it definitely activates mast cells, and
Mm,
that's generating mast cell mediators, something that we didn't measure in our paper.
hmm
And well, maybe we might have measured some of them, but it also causes that vasodilation, like you said. And if you've already got a bunch of leaky vessels and now you vasodilate them, or they're going to leak more. And
Right.
venules, for example, so you've got your capillaries, which are the smallest vessels in your body, and that's where things are leaving the capillaries and entering the tissue. But right
hmm
after that, the venous system starts, and those vessels right after the capillary are called your post-capillary venules, and that's where your histamine acts. That's where a lot of metabolic mediators act, causing leaking. So you're going to dilate your vessels, your capillaries will leak more, and your post-capillary venules will leak more. So you almost double the number of vessels leaking into your body.
hmm
And I'm
Okay.
sure there's other things, but
Yeah, yeah. Next area, very big area, is hormones, menopause, and HRT. And we've talked about this, Karen. What role does HRT play in lipedema? Is there a role postmenopausal in patients using HRT? I'll just, kind of say myself, is it helping certain patients? Is it hurting certain patients, HRT therapy? And I think we both have our opinions about it. It can kind of go either way. And most patients, in my experience, it seems to not make much difference. Some patients seem to have a positive response to HRT. Some patients seem to have a negative response to HRT. Is that correct?
mhm. I agree. And I think anytime you start or stop a hormone, it's risky. So for example, if you start or stop thyroid hormone, your metabolism changes so much and your hair starts falling out. So once you start on a hormone, you kind of want to stay on it, but you want it to be steady. So anytime you have fluctuating, that's when I think you can get into more trouble. So
Yeah.
I have been supporting hormone replacement therapy in women because they've redone the Women's Health Initiative and shown that there actually are a lot of benefits to women continuing estrogen and progesterone, not all of them, and not those with a strong history of breast cancer
Mhm.
or cancer that may be affected by hormones. And I want to make that perfectly clear. I am not saying every woman with lipedema should start them in, hormone replacement therapy. It is a very personal decision that you are making, and there still are risks associated with it. But a low level of estrogen and then progesterone taken to keep that uterine lining small
Mhm.
um, doesn't seem to have a lot of impact. But if you
Mhm.
start it and then you stop it and then you restart it, that's starting to cause problems in your body. And I've seen women run into trouble who have, started hormone replacement therapy and then someone took them off. They said, "Why are you starting that? That's dangerous for you." And then another doctor says, "Why did you go off that? Go back on." And then they go back. That's not a good idea. That is
Mhm.
causing too many changes at once, and the body doesn't really know what to do with that. And it might turn on pathways to start to protect itself, which includes growing more fat. Like it gets that idea that I'm in a famine.
Mhm.
So I
Mhm.
would I would be very careful with it. I would make your decision very wisely,
Yeah.
and work with a provider that's going to check your hormone levels and make sure that you're not too high. Because
Yeah.
if you already have high levels of estrogen because you're aromatizing androgens in your fat, why are you adding on more estrogen? So
Yeah. There's a whole art to doing bioidenticals. We talked about that. And you really
Absolutely.
got to find the right person to trust you with that. And I would say that, if it's going to be done, pay attention to how it's affecting your lipedema. See what goes on after you may start something. Is it getting better? Is it getting worse? Because those hormonal changes can make lipedema worse. But let me ask you this, Karen. If it's getting worse, could that just be a temporary thing that your body's adjusting to, and then maybe at some point it stabilizes and may have a positive
Yep.
impact? Yeah, I
Yep.
guess so.
Yep. Because it takes a long time for
Yeah,
genes to change
yeah.
and for their effects to be seen. And some of the women that I've seen that did have some adverse effects with growth of more lumpy, bumpy tissue on their body started other things at the same time. So they started a bunch of different
Hmm.
supplements and
Hmm.
then medication and then hormone replacement therapy all at the same time. That's a lot. And so you
Yeah,
don't really know what caused the
yeah,
issue. And that's when people start saying, well, you should stop everything.
yeah,
Well, then that, it complicates
yeah, yeah. Okay,
the
quick, let's
issue.
let's move
So if
on.
you are
Quick.
going to start hormone replacement therapy, I would not do anything else at the
Yeah,
same time.
yeah. Okay. A few more questions. GLP-1s, is it safe to be on a GLP-1 agonist for life to help with lipedema inflammation? I think we talked about that, and maybe the answer is possibly yes. Maybe it is, the lowest dose that might be beneficial or achieve a stability in a patient.
It's possible. And I feel though that once you get rid of some of that congested fibrotic tissue,
Mhm.
whether you add surgery on or not, I think at some point, if get the healthy tissue that you want, you could wean off a GLP-1 and maintain it with diet and exercise, and
Mhm.
other
Mhm.
supplements.
Mhm. Supplements. Question about, should the supplement regimen change at all for a patient after surgery? I'll just say that, I designed this supplement program in these three areas: the lymphatic support, anti-inflammatory, and the metabolic support. And, I did it with the idea that it is something that could be taken before surgery for preventative measures, and something that also can be taken after surgery to help prevention and recurrence. I designed it in a way that putting all these different ingredients in these different categories, but in a safe fashion, so it can be taken literally indefinitely. And there's safe dosages of each one of these things in there. But we'll talk about that a whole nother time. Again, the supplement thing, because it's a whole another segment we'll spend on that. Um, any other comments about supplements, Karen?
Yes,
Any other
sorry, I
any,
missed.
any other comments about supplements? Add to
I was
that?
I was trying to think. If I would say that you definitely, surgery does generate healing, and healing overlaps with inflammation. It's some of the same pathways are activated in order to help you heal, which is why people inject stuff into your body when you have inflammation to
Hmm.
make you more inflamed to heal.
Hmm.
So, but you definitely want to have it in, you want it to be controlled. So maybe you might want to consider adding on a supplement that's
Yeah.
anti-inflammatory that you don't have in your regimen right now.
Well, that's exactly, the word is that they are supplements. They're supplementing other things. They're not a replacement for things. I mean, number one is, dietary respectful strategy is always important before surgery, after surgery. Compression is always important with it. Surgery may be a consideration. I mean, these are supplements that are supplementing other things are being done. Unfortunately, there are no medications yet for lipedema. Maybe the closest thing is a GLP-1 agonist that we're now beginning to use in ways. And we're probably, unfortunately, years away from that, about having medications. So, in my mind, you're trying to do everything that you can preventively put the odds in your favor. And that's, why I came up with the supplement program. Surgery, this will probably go on to me. Um, if surgical intervention is done, what prevents lipedema from recurring? I mean, that's a very reasonable and great question. Why after surgery does it tend not to come back? And we don't have the answers. I'll just say that. I think what I am doing in there is I am removing certainly a lot of the buildup of the fat tissue, but also the fibrosis and scar tissue and congestion. So you're massively decongesting areas in ways that I think, and I'll just say this, nothing else probably compares to.
Okay.
I
I don't
mean,
have internet.
nothing else from external compression to even medications can compare to going in and decongesting it. So you're making massive improvements. So why doesn't it come back? That's a really interesting thing. I would say that in the vast majority of my patients, I would say above 95%, it doesn't come back. And I've followed patients for years, but there's a percentage of patients, like the one we talked about, that are at risk of it coming back. In my experience, Karen, they tend to be the ones who have extreme swelling that are moving a lot of movement across membranes. Maybe they have more leakiness in their tissues. Maybe they have more inflammation in their system that is perpetuating the process with things. And even despite the best efforts of things, even with GLP-1s and other things, they unfortunately can get it back with it. I sort of think of it like you're maybe setting it back to its infancy in terms of the process of it. And from that point on, you're doing everything with preventative measures to prevent it from coming back. And thank God in most patients it doesn't, but there's a percentage that it can come back in. And those are challenging patients. Those are the patients that probably have to be on rigid compression protocols afterwards. If they're still having a lot of swelling, they can't just say, hey, I'm not going to do compression. I had surgery done. Those patients need to be remaining in compression garments long term and doing everything to try to reduce inflammation in their body. Thoughts on that, Karen?
I agree with you. I've had a number of those challenging patients, and my feeling is that they went into the surgery with some hidden inflammation that we just didn't know about. And maybe this is the hidden inflammation that we're not testing for in our research studies. And now it's gotten exacerbated by trying to heal the tissue. So I think things like hyperbaric oxygen therapy are helpful. Our CVAC, or cyclic variations in adaptive conditioning, would be helpful. Wearing the compression, the decongestive therapy, exercise, swimming, and some additional anti-inflammatories. Like I have found that in some women who I give GLP-1s to, I need to add back in that diazomin, the micronized purified flavone fraction, in order for them to get better control over that exacerbated repair process. And I
You
think
know,
it's personalized. And now I'm starting to beef up the mitochondria and well, I've been doing that for a long time, but I'm remembering, like, go back, go do that, make sure the mitochondria are functioning to detox. And I think that should become, a kind of a mantra now because of the data. At least that good data came out of that study.
Mhm. I've noticed that I've had a few patients that went through hormonal fluctuations after surgery, and it tended to recur with it. Now, in my experience, doing the surgeries before hormonal fluctuations like menopause is generally helpful in terms of not flaring as much with the hormonal fluctuations, maybe because you removed substrate that is waiting to get more active, or maybe because you've decongested things. We talked about that also. But I've had some patients that went through thyroid fluctuations or other hormonal things that were prone to it. I think looking at MCAS, we talked about that also. I think that patients should really be screened for MCAS. We're now understanding the role it might have in lipedema patients. Maybe those patients, had MCAS that was active after surgery and wasn't really addressed in terms of reducing inflammation prior to surgery.
Yes, the problem with, again, testing for mast cell, like maybe you have more mast cell numbers, they're overactive, is it's so hard to pick up those mediators and identify them because we only test for like 6 and there's 1,000. So which ones are your mast cells secreting? So we're
Yeah.
gonna we're gonna get a paper, because we've been collecting those labs, and some women who have clear cut mast cell symptoms, signs and symptoms, they test
Mhm.
negative.
Yeah.
And
Yep.
so, but even in those, I think it would be wise to consider treatment before or
Yeah.
after the surgery
Yeah.
to control what you think is going on, even though you can't prove it by labs.
Yeah. Okay. We have a question, a live question here. Let me just tackle it. What is the difference between lipedema and lymphedema, and can surgery be performed for both? So terminology is very important. Lipedema is its own condition, typically bilateral with certain signs and symptoms. Lymphedema is its own separate condition, generally unilateral, and can be either genetic or caused by trauma, possibly. Then there can be lipolymphedema, which is lymphedema occurring from long-standing lipedema with inflammation and fibrosis damaging the lymphatic circulation. And then there can also be lipedema with possibly some coexisting lymphedema, where
Yeah.
you've got a patient with lipedema, bilateral, but you've got one leg that may be a little bit larger than the other. And that, in my experience, is occurring because of possibly venous insufficiency in that one leg, or potentially some coexisting lymphedema in that leg. So lipedema, lymphedema, lipolymphedema, and sometimes coexisting. Is that a fair way of looking at it?
Yeah, I would say that. And I kind of think of it as lipedema is in the spectrum of lymphedema. And from the work of Shelley
Mm.
Krasinski, who uses MRI to find fluid in the tissue, it you can find fluid in lipedema tissue. You can. It's just not as prevalent as in lymphedema. So there is a component of lymphedema in lipedema, like you said. It's just,
Mhm.
it's just, it's not, it's not, you can't say it's not congenital because it could be. I mean, it's still, we're still trying to understand it. But from the work out of Eva Sevic's and John Rasmussen's group, they showed that these lymphatic vessels are kind of dilated and the lymph is sluggish in there. And
Yeah.
that's in early stage lipedema. So I think you can say there is something different about the lymphatic vessels in lipedema.
Mhm.
And I called it a baby lymphedema, but it's
Yeah.
really it's in the spectrum. There's something going on, and the
Yeah.
lymphatic vessels are overworking in order to get that fluid out of the tissue.
I want you to, because you commented about this once before about lipedema and lymphedema may be on the spectrum, or lipedema being a form of baby lymphedema. And there were some comments, I remember, on social media that challenged you about that. Like, how can you say that it's a baby form of lymphedema? Um, but you just went into more detail about that. But
Yeah, you have defects in the blood vessel in the lymphatic
yeah,
vessels clearly
yeah,
in stage one. So it's not stage three.
yeah,
So there's not been, I mean, yes, it's stage one can be long-standing too, but you clearly see defects in the structure of the lymphatic vessels too. You
yeah,
clearly see fluid in the tissue as shown by Shelley Krasinski.
yeah,
And we actually completed a study on the lymphopress pump showing that we could reduce edema in the tissue of women with primarily stage 2 lipedema.
yeah,
So,
yeah.
and we could decrease the fat tissue. So that, I think that fluid in the fat tissue, you could press it out and you can actually show the size of the fat going down. So there is edema and lipedema, and that's why we're keeping the name. Otherwise, we would have gotten rid of the edema part of lipedema a long time ago.
Yeah, I just wish we put the term fibro in there, lipofibroedema, but too late for that. So I just want to just answer the thing about surgery with these conditions, surgery for lipedema and lymphedema. So they really are two different things. So lipedema surgery, is what I focus and specialize in. That, typically greatly improves lipedema. It can typically also make improvements with lipolymphedema if it's done a certain way in patients, and improve the lymphatic function even with some lipolymphedema. Lymphedema itself is very challenging. The type of surgery I do is not the surgery for pure lymphedema. That is a different type of surgery, either with anastomosis or lymph node transplantation done by very specialized surgeons around the country or around the world. So different types of surgery for lipedema and lymphedema. Um, and I think that's about it, Karen. We covered so many things, and I see tons
Oh
of
my gosh.
questions here. It's been about an hour and a half, but it is a Saturday. I want to be respectful to your weekend. I want to go out and spend some time with my kids and everybody else's time out there on the weekend also. I want to just say that there's a lot of questions about the supplement program that have come about, and I'm going to save those for a whole segment. I'll just mention that the supplement program is finished. I'm really proud of it. It's about 3 years in the making, and it kind of targets these so-called three areas or three pillars of lipedema, lymphatic support, inflammation, metabolism. I'm really thrilled and proud about it, and it'll be available very, very soon. And there's some information in the link below. But we'll do another segment on that and go through all the questions about it. I want to thank all of you for tuning in. Hopefully, we didn't lose most of you out there with all that detailed, scientific, beautiful stuff that Dr. Karen Herbst shared with us. But thank you all for tuning in to Lippy Logic. God bless you all and have a wonderful weekend.
Thank you.